We are live.
So, good evening, friends, and all the members of All India Ophthalmological Society. As you are aware, All India Ophthalmological Society ARC team has been doing various webinars on the third Friday of every month. Ophthalmology now is a specialty of medicine which has evolved so much that now we have multiple subspecialties, all challenging the concepts and practices which we learned few decades back. But there is still a dearth of subspecialists in ophthalmology across the country, and still the 90 to 95% of this subspecialty work is shared by our comprehensive ophthalmologist. So was the need felt to revise these subspecialty topics with our comprehensive ophthalmologist friends. In this particular episode, we have collaborated with subspecialty society, that is ISCKRS, to help us evolve a webinar which will help our comprehensive ophthalmologists in the periphery to understand the basics of cornea, which they can use in their day-to-day clinical practice. Also, as we have been doing since the month of January, we have an part of the program called Sarange. Sarange is where an individual, a faculty would be presenting to you the gist of all the latest articles in that subspecialty, which has been published in last 2 to 3 years, which have changed the way we are looking at the disease or have decided to treat the disease. So today's Sarange would be presented by Professor Rajesh Sinha. Now, without much ado, I would, before I hand over the further proceedings to Anaga, let me thank profusely Dr. Jeevan Titiyal sir, President ICKRS, for consenting for this particular joint venture, and Dr. Rajesh Sinha and Dr. Namrata Sharma, who has crafted such a wonderful program. So without much ado, can I request Dr. Anaga to carry forward the proceedings? Dr. Anaga, over to you.
Thank you so much, Dr. Prashant. A very good evening to all of you and a very warm welcome to all of you. At the outset, I would like to thank ISCKRS team for collaborating with IAIS ARC to bring out this excellent webinar, and this will be cornea for the general ophthalmologists. So we have a fantastic expert panel today with Dr. Ritin Goyal, Dr. Divya Manohar, Dr. Bhupesh Singh and Dr. Tuhin Chaudhary here, along with the definitely the ISCKRS team, Dr. Titiyal sir, Dr. Rajesh Sinha sir, and Dr. Namrata Sharma ma'am. So we are having a series of lectures, as well as at the end we'll be having the Saransh, which would be a gist of the research articles. So let's begin with the first talk. It's by Dr. Madhu Uddaraju sir. He'll be speaking to us on corneal scraping in microbial keratitis. Sir, can I request you to please start sharing your screen?
Yes, ma'am.
So Dr. Madhu is an excellent surgeon, a brilliant academician, and looking forward to your lovely lecture, sir.
Thank you, ma'am. Thank you so much for those kind words of introduction. I thank the AOS ARC team and ISCKRS for giving me this opportunity to participate in this Cornea For All series. And my topic for today is corneal scrapings. So how corneal scrapings is important for day-to-day practice in the general practitioner, I will try to cover in the next few slides. If you see, the scope of this talk would be under the following headings. How do you collect the specimen? How do you prepare the smear? And how do you interpret the smear? So these are the requisites. So you need a Kimra spatula or a hockey stick or a 15-number blade to collect the specimen from the cornea. Then you need 2 slides, one for KOH and one for grams. So if you see here, they're already marked underneath. And then you have the paracane, and then you have your cultures, that is the blood agar and PDA or SDA. This talk, I limit myself more to the slide preparation so that it is more useful and you can see. So if you see corneal scrapings, it's usually done under the slit lamp, and in non-cooperative patients or children, you can do it under an operating loop or an operating microscope. Usually you use a regular paracane to before we start the scraping and wait for 1 minute. And you keep 2 clean glass slides and you dry it with 70% alcohol so that there is no contamination. And you can also have an aluminum foil over it and sterilize it in your regular sterilizer. Mark underneath with a glass pencil and you put a sticker for getting the patient data. Or if you have an EMR, you can directly transfer the sticker from the EMR. So you start scraping at the beige and go towards the periphery of the edge of the ulcer. And the instruments required for this is a flame sterilized Kimura spatula or a sterile 50-number blade or a sterilized scraper or a hockey stick that we used in our PRK cases. So what are the practical tips that are useful for general practitioners when you do scraping? The most important thing that beginners do is that they touch the eyelids or the lashes. So when we touch these eyelids or lashes, there is a chance of contamination. So to avoid this, you can put a wire speculum even at slit lamp so that you have good exposure and you avoid touching the eyelids and eye margins. Clear, whenever you see an ulcer, don't directly take the material that is directly visible to you. Try to clear the slough first. Until unless you clear the slough, the material which you are going to get will only have pus cells or PMNs. It will not give you any microbiological load. So the first thing is to clear off the slough. Then you see the ulcer proper. Once you see this ulcer proper, with a 15-number blade, start giving upward strokes. And once you give this upward stroke, the material will start to accumulate over the edge of the blade. So this material should be visible to you. Only when you have a visible material on this edge, then you'll have a good microbiological positivity. So as you are doing this scraping itself, you get to know what kind of an organism it is. Suppose you get a gritty sensation, it is more likely to be caused by a fungal organism. And if you have this smooth, cheesy feeling, it is more likely to be caused by a bacterial organism. And whenever the material is less, try to give the material to grams, because in grams you can get the maximum number of organisms. So whenever the material is less, put the first specimen on the gram stain or the slide in which you want to do the gram stain, and then put the remaining material in blood agar, so that the scope of the organisms that can grow in this blood agar or the scope of the organisms that you can see in gram stain are much more. And whenever there is a negative smear, despite your best efforts, ideally stop all the treatment for 24 hours and try to repeat this scraping. And scraping is not only for your microbiological confirmation, but actually therapeutic debridement of ulcers. When you scrape, you are in a way therapeutically debriding lot of the microbiological load. So in such a way, it is ideal to do this therapeutic debridement or scraping every 48 to 72 hours in corneal ulcer cases. This will not only help in to decrease the microbiological load, but also to have a better drug penetration in these cases. So coming to the gram slide and the KOH, first I'll do the gram slide. So grams, if you see, the grams kit is now readily available in the market. You need not collect or buy things separately. When you go to a store that supplies the lab supplies and you ask them for a grams kit, he gives you the entire kit that has whatever material now I'm going to discuss with you. So first, once you have collected the slides, you have to air dry them and heat fix them for 10 to 15 seconds. Then you the slide is flooded with grams crystal violet for 1 minute. Then you wash it with water. Then you stain the slide again with grams iodine for 1 minute and wash it with water. Then you use the decolorizer, that is the acetone and alcohol 1:1. Again, this is also readily available in the grams kit. So once this is immediately the stain is washed away after you put this decolorizer. Now is the time to apply the counter stain, that is carbol fusion. So you apply carbol fusion for 1 minute, wash and dry the slide. So next, so that is the gram stain part. Next, you have to see the KOH. So KOH, you get it in form of crystals. So it is easy to make these crystals into 10% KOH and you store this KOH. And once you have this 10% KOH, put just 1 drop and cover it with a cover slip. So the microscope settings are as follows. So initially for both KOH slide and gram slide, try to localize the area in which you can see the material at 10x. And in KOH wet mount, use the blue ring, that is the 40x magnification with low to medium illumination. Whereas for gram stain, use the black ring, that is the 100x magnification. This you have to increase the illumination for gram stain. Whereas in KOH, you want to use a medium to low illumination, so you have a better contrast. So these are the microscope settings. And these are how different organisms look under the gram stain. So if you see GPC in pairs, it is more likely to be caused by Streptococcus species. And if you see GPC in groups, it's more likely to be caused by staph. And these are little difficult to identify. That's the gram negative because they get mixed with the background. So these rods that you are seeing are the gram negative bacilli, or that is Pseudomonas that we commonly see. Then it's fungal filaments. You can see this slender long filaments in the gram stain, and this is how they look in the KOH wet mount. And this is atypical microbacteria. So the atypical microbacteria, these organisms do not take up the stain. If you see in this blue slide, there are these white slender things that are the atypical microbacteria. So this negative staining is the hallmark of atypical microbacteria. Because of large amount of lipid in cell walls, they don't take up the stain. Next is acanthamoeba. Again, acanthamoeba you can appreciate as this double-walled cell in a simple KOH wet mount. Nocardia, this sometimes beginners may get confused with fungal filaments. But if you compare with fungal filaments, they are very slender. They are filamentous bacteria, and they are like this dot-like filaments in a continuous fashion. They are more slender when compared to fungal filaments. Next, you have pythium. Again, these can mimic the fungal filaments, but they are more broader and they are ribbon-like. There are no hyphae or branching in pythium. That is how pythium looks both in KOH and in gram stain. So that is the basics of corneal scraping. So why it is important to do corneal scrapings is you want to identify the organism. So by identifying the organism, you are going to give a specific therapy for the ulcer. So what is the advantage of giving a specific therapy versus giving an empirical therapy is when you give a specific therapy, there is better drug compliance and the patient heals faster. When you are giving an empirical therapy, suppose it is a fungal ulcer, you are also giving an antibacterial along with the antifungal. The antibacterial kills the commensal bacteria that are there in the eye. And when you kill this commensal bacteria, they actually help you fight against the fungus. So you are delaying the healing process when you give an antibacterial in a fungal case. So the whole idea is to give a specific therapy. So once you do a simple scraping, it doesn't cost much. When we compare to the other equipment that we invest in ophthalmology, a clinical microscope hardly costs around 30 to 35,000, and the grams kit comes around 1,500. So I think whoever are seeing more cases of ulcers, I would urge through this talk that if they can just do a simple gram stain and KOH, they would be treating their ulcers better and doing more justice to the patient. Thank you, ma'am. Thank you for the opportunity.
Thank you. Thank you so much, Dr. Madhu. It was an excellent presentation. We have our expert panel here too. Can we all have our videos on, please? So, Dr. Ritin, I would like to ask you a question. So now that sir has given us the overall picture on how a corneal smear is done. Now, many times in our private practice also, we get patients who are already on multiple treatments or who has come to you for a second or a third opinion. So they may have had already antibacterial or antifungal drops already going on for the past 3 to 4 days. At that point of time, is it still worthwhile to go ahead with a corneal scraping? And second question is, when is the earliest that we should do immediately on the first day? And out for the benefit of our viewers.
Yeah, thanks, Dr. Anika.
Yeah.
Am I audible?
Yes, but we can't see you. Requesting you to put on your.
Just give me a moment, please.
Yeah.
Right.
Yeah. Thank you.
So, so I think corneal scraping is very important, and the earlier that we do corneal scraping, the better it is. And whenever you have a patient who's coming in with an ulcer, with an infiltrate, before starting any therapy, if we can do corneal scraping, the pickup rate of those corneal scrapings will be the highest, of course. If the patient is already on multiple medication, then it's much harder. You could take a smear and you may not pick up so many organisms on the first go. So it may be a little bit harder. I don't see a reason why we should wait. Only logistical reasons for waiting would be that you don't have, the culture media or the slides available with you. So microbiology consists of both parts, taking the smear on the slides as well as sending it for cultures. I think the slides really help because identifying fungus is quite easy, not just a microbiologist. And once that we are able to make sure that there's no fungus, our treatment protocol changes drastically, and sending the smears would for cultures can really help us confirm what we're dealing with. Another thing that I would definitely say is that, supposing you've done a good corneal scraping, you've sent the smears, you couldn't find anything. There's no harm in repeating scrapings again once that you feel that the therapy is not really working.
Correct. Dr. Tuin, wanted to ask you now, if you have an ulcer, then is it best to scrape it in the center or in the edge?
Definitely in the edge, because that is the area where these organisms grow. And that one more thing, that what the doctor, this Madhu has told, that you should go for therapeutic debridement every 48 to 72 hours. I feel that it should be every 24 to 48 hours. Because if you delay it for 3 days, then these organisms, that means this bacterial or viral load or fungal load will be that means delayed or less, more. Okay, so to reduce the fungal load, you should do it every day or every second day.
Okay.
Great.
Yeah. Dr. Bhupesh is there. Dr. Bhupesh, one last question to you is, how would you rely on the microbiologists who are available now? For example, all private practitioners, suppose you don't have a clinical microscope in your own setup. So is it good to have as a backup, you send it to the local microbiologist? And what has been your experience?
So my experience after LVPI is totally different in private practice, actually. So it's very difficult to manage all these ulcer cases in private practice. So I started depending on my clinical skills, the clinical examination things. But many times you require a microbiologist. So the best part is you have to locate some good person in the ophthalmic fraternity only, because normal microbiologists cannot diagnose these cases. I've sent many times, they send inadequate sample or no organism found. Most of the time the diagnosis is this. But now we have a tie-up with the Shroff charity, so they do very good microbiology. So best part is to locate a good medical college microbiologist or some good big hospital setup. And you cannot depend on the general microbiologist for your eye diagnosis. So that is the thing.
Okay.
Yeah.
Thank you
And
so
you should
much.
also speak to them that you are suspecting a particular organism, so that they look.
So that a better communication and as a good team effort, you can finally come to the diagnosis. Right. Yeah. Thank you so much. So we'll move on to the second talk by Dr. Rohan Thakkar. He'll be speaking to us on managing perforated corneal ulcers. So now we have seen how corneal ulcer, we can take a smear and send it for examination. But if it doesn't work and the patient has already come to you with perforation, how we are going to manage? Dr. Rohan is going to speak to us. Over to you.
Hello, ma'am.
Hello.
Am I audible?
Yes.
Yeah. So good evening, everyone. At the outset, I would like to thank the AIOC ARC team and the ISCKRS, and especially Professor Rajesh Sinha sir for giving me this opportunity. So after a detailed talk on examination, the scraping examination by Dr. Madhu, I'll be speaking on managing perforated corneal ulcers, an overview of surgical and non-surgical management. So as we all know that perforated corneal ulcer is a medical emergency and it should be addressed within the first 24 hours. So coming to the basics, the causes of perforated corneal ulcers could be divided into infectious causes or non-infectious causes. The infections include bacteria, herpes, or fungal keratitis. And the non-infectious causes include trauma. It could be a penetrating or a chemical injury, severe dry eyes, or autoimmune disorders like rheumatoid arthritis, SLE, PUK, and Murren's ulcer. So before starting the treatment, a thorough history and a corneal workup is necessary. When you take the history, patient will give a history of sudden reduction in the vision, often associated with pain. There might be history of ocular trauma, ocular surgery, herpetic eye disease, contact lens use, or most commonly, there is a history of patient taking self-medication from a direct medical store and applying topical steroids. The systemic history should include a history of diabetes mellitus, rheumatoid arthritis, and immunosuppression. On careful examination of the slit lamp, you will see the iris prolapsing through the perforated corneal ulcer. And on fluorescence staining and visualizing under the cobalt blue filter, you will see a positive Seidels test. Before starting the treatment, coming to the diagnosis is important. So a very gentle corneal scraping should be done. Do a gram stain KOH mount and send the material for culture and sensitivity. It's very important that in contact lens users, the contact lenses, the case and the cleaning solutions should also be sent for examination. And always do a random blood sugar in such cases. Coming to the principles in management, the first and the foremost principle is supporting the globe. So whenever we have a perforation, first shield the eye. Second, form and maintain the AC. So formation and maintain the AC is done by aqueous suppressants. Third, promotion of the wound healing. And in perforated corneal ulcers, I always start on oral antibiotics like oral ciprofloxacin 500 milligrams to 1000 milligram twice a day and tablet doxycycline 100 milligram twice a day. The management of the corneal perforation options are tissue adhesive glue such as cyanoacrylate glue. Second, amniotic membrane transplantation. Third, it could be a patch graft, either a Tenon's patch graft or a corneal patch graft. And fourth, penetrating keratoplasty, that is therapeutic keratoplasty. Now, if the perforation is less than 0.5 millimeters in size, and if it is self-healing, in such cases, only placing a BCL, aqueous suppressants, and antibiotics would suffice. But if the perforation is more than 0.5 mm to 2 millimeters in size, in such cases, tissue adhesive glue, that is cyanoacrylate glue plus a BCL works the best. However, in perforations larger than 2 millimeters in size, these are the following options where we can use a tissue adhesive glue with a drape and a BCL. Second, Tenon's patch graft. Third, multi-layered amniotic membrane grafting. Fourth, conjunctival pedicle flap. Fifth, smile lenticules could be used for corneal patch grafting. And the last is therapeutic plus tectonic corneal grafting. So this is the most easily performed procedure, tissue adhesive plus BCL. In this, we use a cyanoacrylate glue, which works by the method of polymerization. It is very fast in action. The action starts within seconds, and usually it is complete within a minute or two. And it also has some bacteriostatic effect. It also disrupts the stromal melting. This could be even done on a slit lamp. This is a small video to show. First, we should remove the surrounding epithelium. Second, we should dry the corneal perforation bed. And third, take very little of glue. You can take it from the behind side of the Mersol sponge, or you could take it on a small cannula and apply it on the perforation. Leave it for a minute and then apply the BCL. Don't take too much, otherwise a huge mound will be created and it can cause irritation. The advantages are it is cheap, it is readily available, and the general ophthalmologist can quickly and easily perform this procedure. The disadvantages, if you apply a lot of glue, it will cause a huge mound and it can cause irritation and giant papillary conjunctivitis. For larger perforations, a glue with a drape and a BCL can also work. In this, over the perforation, after drying the perforation, cyanoacrylate glue is applied first. Then a small piece of sterile drape is placed over it. Then third layer of glue is applied, cyanoacrylate glue, and then after letting the glue to dry, the BCL is placed. So it acts by four layers of protection: glue, drape, glue, and a BCL. Conjunctival Tenon's pedicle flap is good for peripheral perforation or even for central perforations where there is a poor visual prognosis. In this, we advance the conjunctiva and the tenons, and it is taken 1 to 2 millimeters further away from the perforation. So covering 2 millimeters more than the perforation area. Amniotic membrane transplant works very well. In this, we take small pieces of amniotic membrane and fill up the perforation first. After doing that, another layer of AMG is placed on the cornea, and then it is secured with sutures or glue, and then a BCL is placed on top of it. It has a lot of growth factors and it will aid in epithelial healing. And another advantage is there is reduced inflammation and reduced vascularization. You can see this video. After placing the small bits of amniotic membrane in the perforation, then a large layer of the AMG is placed so that it covers the entire cornea, secured with a glue, and then place a BCL on top of it. Tenon's patch graft could be done for perforations which are peripheral, but in infectious cases, Tenon's patch graft is not advisable because the infection, the microorganisms will eat up the Tenon's material. For larger perforations which are more than 3 millimeters in size and where a lot of sloughing is present, therapeutic keratoplasty is the option of choice. The newer advancement in corneal perforation treatment is we can use the corneal lenticules, which we retrieve from the smile surgery patients, and these can be used to close the corneal perforations. So take-home points would be act immediately. Glue and AMG work for small perforations. Patch grafts are good for peripheral perforations or even for central perforations till the cornea is available. And therapeutic penetrating keratoplasty for large perforation with lot of sloughing. We can also do a mix and match of few procedures, like we can do a Tenon's graft with a glue. We can do glue with drape. So you can mix and match few options and treat your case. So thank you for your kind listening. Thank you so much for the opportunity, ma'am.
Yeah, thank you so much. It was an excellent presentation.
Thank you, ma'am.
Yeah, can you stop sharing? Yeah, yeah. So is Dr. Divya here already? Can't see her. Okay. Dr. Ritin, would you like to add anything, any tips to his presentation? Dr. Ritin, yeah.
Yeah. Right. So I'd like to ask a question that, and I'd like to ask this question to Dr. Bhupesh. That Dr. Bhupesh, what is your go-to first line, tool? Is it Tenon's patch or a corneal tissue? And when would you prefer a corneal tissue versus any of these accessory materials, not allograft?
Hi. So managing corneal perforation is based on the case-to-case basis, actually, Ritin. So definitely in small cases, 2 millimeter or less than 2 millimeter, the first goal is to use glue only here and then put the glue, because that is the safest thing, I feel. And you can repeat it also if it doesn't work. And the second option, again, then you can go for the Tenon's patch, or we can use the drape or BCL, these things for 3 millimeter types of thing. And regarding the corneal tissue, if these things doesn't work, then comes the cornea in picture. You can put the patch graft, you can use the cornea and do the eccentric patch graft or central patch graft, whatever, where is the perforation located. I didn't try the smile lenticle for perforation, so I'm not sure about that. But definitely this is the stepwise management of the perforation, depending on the grade of perforation.
Excellent. Thank you so much.
One thing, can I tell something? That
yeah, Dr. Turin, yes.
This amniotic membrane, if it is true perforation, it won't work. Try to imitate. So amniotic membrane, if it is impending perforation only or very small, there is no leak, then only it will work. Otherwise, whatever you do, it will not work. In those cases where there is amniotic membrane, where you put it, if there is no infection, definitely you can go for this Tenon's patch graft, because the advantage is that Tenon's patch graft, after some days, it will be, because it will produce some sort of this tissue fibroblasts, and that will be incorporated into the corneal stroma. So even if it is thinned out in future also, it will be giving some good support. So that is the main thing. And another thing, that in cases where if you have no other options, then you can go for pedicle conjunctival graft. Okay.
Right.
Thank you so much. So we move on to the next talk by Dr. Prabhat Nankia. He would be speaking to us on corneal suturing and traumatic perforations. Yes, Dr. Prabhat, please share your presentation.
Yes, madam. Can you see my slides, please?
Yes, please go on.
Just 1 second.
Yeah, you can make it full screen.
Okay, yes.
Fine.
All right. Is it all right now?
Yes, perfect.
Okay. So, good evening, everyone. I'd like to thank ARC team and also, of course, Iskaris team and Sena sir, who has just joined us for this wonderful opportunity. So, the outline of my talk is we'll discuss a little bit about the introduction and the classification of ocular trauma. How do we plan preoperatively what all to do before you actually take the patient up for suturing? Corneal suturing proper with the tips, tricks, and technique. Special cases, corneal patch grafting, and the key take-home points. So the Birmingham eye trauma terminology classifies eye injuries into closed and open globe. So open globe can be ruptured due to blunt trauma, and lacerations could be penetrating, that is a entry wound only, or perforating, that is entry and exit wound. So when the patient reports to you, take a detailed history, time since injury, nature of the injury, whether it was a projectile, because that suggests that there could be an intraocular foreign body, a sharp instrument or a blunt trauma, whether initial treatment has been done elsewhere, tetanus prophylaxis, IV antibiotics, or the patient has already undergone a primary repair. Detailed evaluation including visual acuity, intraocular pressure, not for a frank tear, but only for a lamellar tear of such situation. RAPD, of course, to give you a quick guide to the prognosis. Avoid USG in open globe. Plan for CT if intraocular foreign body is suspected. And of course, always examine the other eye. So document the site and extent of injury. So they've also classified the globe into 3 zones. Zone 1 is from the center of the cornea to the limbus. Zone 2 is beyond the limbus, 5 mm all around. Zone 3, anterior to the insertion of the recti, and zone 3, posterior to the insertion of the recti. And of course, there's the ocular trauma score that looks at the initial vision, whether there is a presence of a globe rupture or not, presence of endophthalmitis, a perforating injury, an RD, and an RAPD. And it uses all of these factors to prognosticate the vision that you're likely to achieve after primary repair. Also look at the associated iris prolapse, hyphema, presence or absence of cataract, and ALC rupture. So when do you not suture? That is also as important as when you suture. If you have a small lamellar tear, a little bit in the paracentral area or in the periphery, or if you have a full thickness tear that's smaller than 2 millimeters where the AC is still formed, you may consider putting a BCL, but with or without cyanoacrylate glue, but it's important to ensure that the wound is watertight. So if the AC has collapsed, then this option is no longer applicable. Sometimes patients report a few days to few weeks after the injury and the wound is already scarring and the Siegel's test is negative. So based on the location and size, you may or may not need to suture these patients. Now, again, there are always caveats to such a situation. So if you look at this, the upper image here, this lady had undergone a manual SICS elsewhere, and she had a leaky scleral tunnel that is not visible in the photograph. But in addition, in the center of the image, you can see a deep line. That is a lamellar tear. So we did a scleral tear repair, of course, but we also sutured the lamellar tear because such a deep lamellar tear acts like almost like an RK incision and will introduce or induce unpredictable level of astigmatism, and you really don't want that. So then you try and counter that by doing, taking the sutures. So what all do you need to do pre-op? So for small wounds where the AC is well formed and the patient is cooperative, you may consider topical anesthesia. Otherwise, any complex corneoscleral tear wound, corneoscleral tear with iris or uveal prolapse, you need to go ahead with general anesthesia. Always check for the Siegel's test, pre-op injection tetanus, pre-op IV antibiotics, IV steroids, X-ray or CT scan, physician fitness, and pre-op surgical planning. So when I say surgical planning, what I mean is where are you going to take the sutures? How are you going to take the sutures? All of that, because it's really important to go ahead with a plan so that you face less surprises on table. So how do you pass a corneal suture? Well, it's essential that you pass the suture directly perpendicular to the corneal tissue as seen in the upper left image here. And because we use steno nylon for corneal suturing, it has a short arc length. It will find its way through the deeper layers of the cornea and come out in the other side. So what that means is you will essentially then have if you take good care, you will have equidistant length on both sides with a deep suture that is 90% depth, never full thickness, and always ensure that you are radial to the wound. So ideal suture depth is 90% with equal length on either side of the wound. So in the image A here, the suture is deeper than 90%. It's actually full thickness. This can lead to suture tract leaks, which can introduce infection and may prevent the AC from forming. The image B, where the suture is a little bit superficial compared to 90%, this can lead to a posterior gape that may or may not be visible post-operatively. So try to aim for the 90% as much as is possible. So again, when you have a shelf tear, we tend to apply the same logic that we have used previously, is that at the upper edge of the tear, we try to maintain equidistance. Now, when you do that in a shelf tear, there will actually be tissue override. So how a shelved tear differs is that you need to maintain equidistance at the lower end of the suture, at the back end of the suture. So superiorly, you actually pass it close to one end so that inferiorly it is equidistant. I hope that this is clear, where C is equal to D in the lower left image. Again, how do you ensure a watertight closure? By ensuring that the length of the suture is slightly greater than the distance between two sutures. So there will be a small zone of overlap between the compression zones. Each suture induces a rhomboid shaped compression zone. So the compression zones need to overlap to ensure a watertight closure. If the gap between the sutures is greater than the suture length, then there will be suture leaks. So each wound in the cornea differs. I often say that corneal wound suturing is very, very different from skin suturing. So when you look at a wound, say, that is just on the cornea, towards the periphery, your sutures will be longer and closer together, and towards the center, they will be shorter and a little bit farther away. So you do that so that you can preserve the corneal shape, because remember, the cornea is slightly steeper in the center as compared to the periphery. So the idea of doing this kind of suturing is to try and, as much as possible, bring back the original corneal shape. This also ensures that there are fewer sutures closer to the visual axis, and therefore the amount of scarring in the visual axis is minimized. When you have a sclerocorneal tear, the limbus is the only anatomical landmark that you have. So particularly if there is a significant wound gape, if you suture the limbus first, that gives you a good starting point to be able to achieve a good and appropriate anatomical closure. So after taking your limbal suture, first you finish the corneal side like I have already discussed, and then you open the conjunctiva step by step and take the scleral sutures as well. With a geometric wound, it is a good idea to suture the limbus first, like we discussed in the last slide, and then the apex, and then finish the sides using all the normal principles of corneal tear suturing. If there is mismatch of depth in the suture that you take, there will be overriding or underriding of tissue in the long run, which may lead to healing issues, astigmatism, and other issues. So let's look at a couple of cases of corneal tear repair. So this was a 5-year-old girl who allegedly had trauma to her left eye with scissors one day prior. Now, she didn't really allow us to evaluate her very well pre-operatively, but this is what we could see, and therefore I have drawn this wound with prolapsed iris. But so it's always a good idea to first do your side port when you start suturing. Through that side port, you may inject a viscoelastic and try and reposit the iris. So that is what we were doing here. So in addition to iris, there was also fibrin in the wound. So then you start suturing close to the apex or at the apex. Maintaining equidistance and radiality. Ensure a watertight closure, always bury the sutures. Now the bubble is not going beyond that area because of the clot. So you pull the clot out of the eye. Do a visco wash. And suture the side port. Now, another special situation is patch grafting. Patch grafting is not routinely recommended for corneal tears, but this was a 13-year-old male with alleged injury to his right eye with the edge of a wall 4 weeks prior to presentation. He had not taken any treatment up till that point, and his vision in the right eye was counting fingers at 1 meter. So in a wound like this, that is an old wound with a significant iris prolapse where you're already seeing scarring, you abscise the iris first. We are unable to oppose the edges, so this does require a patch graft. Use the preserved cornea, mark the edges of the wound, and then mark the patch graft that you're going to dissect. You need somebody to hold the patch graft for you. Take 2 sutures. So these 2 sutures will then act as anchoring sutures for you. And complete the suturing of the 2 sides, following all the rules of corneal tear repair. And finally, suture the base to the clear. Ensure watertight closure. So this is post-operative 4 months. The vision improved to 624. There is a little bit of cataract, which required cataract surgery. So post-operatively, topical and oral antibiotics and steroids should be prescribed. Frequent follow-ups. Rule out a leak in the post-op period by repeating your serial test. Standard suture removal is done at 3 months, but loose suture should be removed as soon as they are noted. And biometry is normally advised 2 weeks after suture removal if there is a cataract. If the Mayas continue to be irregular, you may need to use a topography instrument to get a simulated K value for IOL calculation. So take-home points. Corneal suturing differs significantly from skin suturing, mainly due to its proximity to the visual axis. Try as much as is possible to apply the guidelines discussed, but it's important to understand that tears will always surprise you. So whatever you think you plan initially, on table, it will always be different. So you need to just prepare for that a little. You need to be alert and creative and adjust your plan. Suture the limbus first in case of coniosteral tear. Cyanoacrylate glue is only used in cases where there may remain a leak in between the sutures that you have taken. Patch grafting is only for special situations where there's frank tissue loss or wound edges are not getting opposed. And always ensure a watertight closure. I'd like to acknowledge the contributions of Dr. Bhaskar Srinivasan to this presentation. Thank you. Thank you, everyone.
Yeah, excellent. Thank you so much. Welcome, Professor Dr. Rajesh Sinha, sir, to this webinar.
Thank you, madam.
Yeah. So, Dr. Rajesh would like to ask you one question regarding this. So, he presented very well how you can suture a corneal perforation, traumatic corneal perforation. Suppose a patient also has a traumatic cataract along with it. How would you approach the case? And secondly, if the patient's vision is very less and you're suspecting some posterior segment pathology, how would you approach that case?
If the patient has a cataract, then in that case, we should see whether the capsule is breached with lens matter coming into anterior chamber or not. If that is the case, if the capsule is ruptured and the anterior capsule is ruptured and the lens matter, there can be different types of cataract. Because of blunt trauma, the posterior capsule ruptures and then you can have a sudden development of cataract. But since he was talking about the perforating injury, so most of the times it can cause anterior capsular rupture by that perforating injury. There can be posterior rupture as well. So if there is lens matter in anterior chamber, it should be aspirated out and the patient should be left aphakic because you are putting a corneal suture. And you should put the intraocular lens after removing all the sutures and after the corneal astigmatism, etc., stabilizes. Then only one should put the IOL. But lens matter, if it is there in the anterior chamber, then it should be removed. But if the lens matter is not in the anterior chamber, and there may be just a tear in the capsule and then there's a total cataract, but there's no lens matter in anterior chamber. In that case, it's better to do the suturing of cornea first, let everything get stabilized, and later on you can see the exact margins of the tear as well of the capsule, and then go ahead with the cataract surgery if the lens matter is not in the anterior chamber. That is one thing. And that's what I could see in one of the cases. It appeared that there was some amount of cataract which was there at that time itself, but he just sutured it well and then it was looking good in the post-op period. And then cataract surgery can be planned later. If there is any, say, foreign body that has caused, entered into the cornea, has caused this trauma or there is a vitreous hemorrhage, etc. In that case also, it's better to do the repair first so that your globe integrity is well maintained And once it is well maintained, you remove the suture, and then of course you can investigate and do ultrasound if it's not visible due to cataract, and then go ahead with the cataract surgery and do a vitrectomy along with that. You can combine the cataract surgery with IOL implantation with a pars plana vitrectomy. Or the only situation wherein you may have to do a little earlier surgery is if the patient is having a retinal detachment as well. But most of the times in a traumatic injury, what happens if there is a corneal, there's a corneal trauma, there's a corneal laceration, then the force is more onto the cornea, then in that case, the retinal detachment does not happen at that time. Or if there is a dialysis also that has happened because of a blunt injury that is causing a corneal laceration, and there's a retinal dialysis, then also detachment does not happen at that point of time. So maybe we can do a repair first, and then later on, once the anterior chamber clears up, stabilizes, we can evaluate the retina and then go ahead. So in any case, we should do it at a later stage once the cornea stabilizes.
Yeah, Dr. Bhupesh, you want to say something? Yeah.
Yeah, so I had a question for Dr. Rajesh. So, sir, how we can manage the iris? Because many cases we get iris prolapse. So, how to decide what are the criteria in which we have to excise the iris tissue, in which we have to deposit the iris tissue? So, how you decide these points?
If there is an iris prolapse and it is less than 48 to 72 hours, then in that case, what you can do is that you can reposit the iris, as very nicely pointed out by Prabhat, that you make a side port, you can inject viscoelastic, then you can remove the membrane, reposit the iris, and at the end of the surgery, you can inject intracameral antibiotic. But if it's more than 48 to 72 hours, then it's better to do some degree of abscission. Now, earlier, people used to advise complete abscission of iris. Long back when I was senior resident, my mentor, Dr. Vajpayee, he advised me to do just a little bit of dissection in the iris and remove the superficial one and leave the posterior, and we started doing that, and it worked very well. So you do have a thin layer of tissue still present in that area. So you dissect a little bit of iris there so that you have a superficial layer that you remove and reposit the posterior one. And then again inject intracameral antibiotic, and it works quite well. Because if you do a complete abscission, then later on you have to do a suturing, or maybe during that period only you will have to do a suturing. Sometimes what happens that if there's an iris prolapse and it is more than 72 hours, then there is a contour of the iris that becomes rigid like that. And if you reposit it, it still has a fold like that. So that is all, again, a reason why we should do a little bit of dissection of the iris so that it flattens, and you will have a trans-elimination later on, because the iris will become very thin. As if it is badly damaged, sometimes in some anterior segment surgery, that is how it will look like. But still, there will be some layer of tissue there which will prevent photophobia, etc.
Yeah,
Can I
thank you,
add
sir.
something?
And probably you need to look at intraocular foreign bodies also. So a sonography or a X-ray
Yeah.
might help. That also
Absolutely.
will need to rule out in these patients. Only thing is, in an open eye, would you do a USG-B scan? I know, very gently, but if there is a bigger tear, then it becomes very difficult, no, to do a USG-B scan to rule out retinal detachment or vitreous hemorrhage at that point of time.
One can do an X-ray, that is one. And the other thing is that there's no urgency to rule out foreign body in an open eye. We can do the repair first, and whatever is there behind,
Yeah, can be.
we can handle it later on.
Correct. Yeah, Dr. Twin, you were saying something?
Yeah. Just wanted to tell you that, Dr. Rajesh, whenever you are having this iris prolapse or anything like that, what is my suggestion that for general physicians, that you should go for just localized iris abscission. Because what happens that if you keep it, then there will be some touch, this iris will be touching the endothelium of the cornea, and then this endothelial tissue will slide off the posterior surface, and then it will grow over the iris tissue. and then that will result in localized corneal edema. So my suggestion is that you go for this bit localized this iridectomy, and then in future you can go for iris suturing. We have heard that
Yeah,
localized
that is
corneal.
one option. But if you do a dissection of iris, which actually earlier it was never written in any textbook, but this, what I told that this was suggested by my teacher, and we started doing that, and it works quite well because that flattens the posterior
Yes,
layer,
that also I have done that
flattens
also.
well, and it doesn't come up and doesn't touch the endothelium.
But if you don't do anything, then it will be definitely touching the posterior peripheral cornea.
Absolutely.
So let's move on now to the next talk. I'd like to invite Dr. Ikeda Lal for her talk on corneal tattooing, improving cosmesis.
Very good evening, and I would like to thank ARC as well as Scaris for making me a part of this wonderful session. And am I audible and are my slides visible?
Yeah, make it full screen, please.
Yes, I'm just doing that.
Yeah.
Right. So I will be talking about corneal tattooing, how to improve cosmesis in these kind of patients where we have a blinding, disfiguring corneal scar with nil visual prognosis. So the treatment options that we have for cosmesis include cosmetic contact lenses, but usually we have issues with fitting, as especially in irregular corneas, they might not fit well. Then there is the additional hassle of having to wear and remove them daily and hygiene-related issues that are present with cosmetic contact lenses. The second option that we have is cosmetic keratoplasty. But as we all know, with keratoplasties, these patients require follow-up. They require suture removal as the sutures can become loose, and there is an additional risk of graft infiltrate as well as graft rejection. Again, if they have rejection, they will again have opacification, and that will decrease the cosmetic outcome. And then the last option that we have is corneal tattooing or keratopigmentation, and this is what we will be discussing in detail today. So let's look at the different techniques of corneal tattooing that we have. So the three common techniques that we can use, first is the intrastromal pocket creation, wherein an lamellar pocket is created with a small incision and is dissected, and then the pigment is implanted in this pocket. So it can be a pre-sterile dye, it can be dry pigment, or it can even be soot, which we can collect by burning a candle and then collecting it in a sterile way and putting it inside. Now, this is usually the gold standard, and it works very well because it fades the least over a period of time. But this is not a suitable technique for all our patients, as it is difficult to perform in patients who have irregular scarring, thin corneas, or even pretheisical eyes. Then we have a creating of a flap. Now, this can be done either manually or with a femtosecond laser or with a microkeratome even. Now, when we use a femtosecond laser to create the flap, if we have a very dense corneal scar, the femtosecond laser might not penetrate. So this is more desirable for patients who maybe have total cataract, but they do not have visual prognosis. Again, it adds to the cost of the procedure. Then lastly, we have the technique of anterior stromal puncture, wherein we just use a fine needle like a 26 gauge needle. We put the pigment on top of the cornea after removing or maybe not removing the epithelium, depends on the indication. And then we just drive this pigment into the anterior stroma. Now, this can be done for all of these cases, which we have thinner corneas or irregular corneas or pretheisical eyes, all kinds of cases. But the problem is that this is a very slow process, and we might not get a very uniform pigmentation with this technique. So what do we do in cases like this? So I would like to talk about this, the tattoo gun device that we have been using now for the last couple of years, and this solves this problem. So this was imported from China way back in 2018. And I would discuss in detail how the procedure is performed, how effective it is, and the safety profile of this new technique. Now, this is what this device looks like. So we have the console over here. And on this, with this console, there is a handpiece attached to which we can use the disposable needles. And then we can increase or decrease the oscillations per second from this console. And this is controlled by a foot pedal. and we can increase and decrease the length of the needle that protrudes out of this device. Normally, as all our patients have brown iris and dark pigmentation, we use the jet black tattoo ink for these cases, because if we use brown, it tends to fade away over a period of time. And all of this has an adapter, and we can control with the help of a foot pedal. Now, before I talk about the procedure per se, for any technique of corneal tattooing, what is the pre-operative evaluation that we need? So first and foremost, to document the visual acuity, whether the patient is PL positive or PL negative is important. The intraocular pressure can be measured with tonopen in these cases, because your other devices might not work. And it is important to do this because if the patient has intractable glaucoma or an absolute eye, they can develop corneal edema over a period of time, and the fading of this pigment is more likely in these patients. Taking a good photograph, face photograph, as well as slit lamp photography to explain to them and also to document. An anterior segmentosity for patients where we suspect corneal thinning, so that we don't have an inadvertent perforation intraoperatively. An ultrasound B scan to again document presence of retinal detachment, or if we are suspecting phthisis or prephthisical eyes. And last but not the least, to take an informed consent and tell the patient about possibility of the pigment fading away over a period of time, keeping the expectations realistic and the need for repeat procedure in future. So now let's look at the surgical video of this 26-year-old patient who presented to us with left eye esotropia, spheroidal degeneration, and corneal scarring, and with a nil visual prognosis. So here, what we need, the first step before any tattooing procedure, is that we need to have a smooth corneal surface. That is the first and foremost thing. So here we are using a number 15 blade and just debriding this irregular spheroidal degeneration so that we can go ahead with the procedure. Now, as we can see, this patient in the center has this kind of a linear corneal scar, and the cornea was quite thin in this area. So for patients like this, it becomes quite challenging to create intrastromal pocket and place the pigment. And this is how this technique comes in handy. We can see the patient is under topical anesthesia. So most of these cases can be performed after, under topical anesthesia if our patient is cooperative. Now here what I'm doing is I'm using a pre-sterile jet black tattoo ink, which on a 1 ml syringe mounted on a 27 gauge hydrodissection cannula. And then we just gently place it on top of the cornea. And now our aim is to drive this pigment into the anterior stroma in a fast, uniform way. So this is what this handpiece attached to a disposable needle does. So these are the needles which can be replaced, and we keep the setting, the length of the needle to minimum, usually around 0 works well in our experience, because we just need a very small length of this needle protruding out. So this drives the pigment into the anterior stroma. And this can be repeated as when needed. So we wash off and then we look where all excessive pigment is needed, and then we can go ahead and place this dye again and repeat this procedure. Usually we need to do this about 2-3 times to achieve a smooth pigmentation. And we can see we can go right up to the limbus, very close to the limbus, and go to the periphery and achieve quite a precise pigment throughout. So this is the advantage of this technique. And towards the end, we place a bandage contact lens. Now, this is the post-operative outcome of this patient, immediate post-op, and he was very happy with his cosmetic outcome. Now, this is a 18-year-old female patient with right absolute eye and inferior corneal opacity, as well as a divergent squint along with hypertropia. Now, she has only a focal inferior corneal scarring. Again, in these patients, to be able to create a stromal pocket only focally in that area can be very, very challenging, and inadvertently the pigment tends to get diffused out. So here, when we want a focal area, maybe in a large PI, we want to cover that area, or if there is any corneal scar that we need to cover with tattooing only in one quadrant, then this technique comes in very handy because this needle is very, very precise. So this is another indication how we can use this device. And this is again the immediate post-operative result. And it can also be combined with other procedures. Since it is a safe technique, we can combine it with EDTA chelation patients who have BSK first. We can remove all this calcific deposit and then go ahead with tattooing, and can also be combined with squint correction, as a lot of these patients would require a squint surgery as well. Post-operatively, these patients are prescribed steroid eye drops and tapering doses. Usually, I like to use either fluoromethalone or loteprednol. Antibiotic eye drops for about 10 days, and lubricant eye drops, which we like to continue for some more time. And the bandage contact lens, typically I like to remove after 10-15 days so that the epithelium heals well and the patients don't become symptomatic again. So we analyzed our data over a period of 2 years, and we looked at our cases, which were 21 eyes of 21 patients. And the most common cause of corneal opacification for these cases was actually trauma. And we graded the level of satisfaction at a minimum follow-up of 6 months, grade 1 being extremely unsatisfied to grade 4 being extremely satisfied. And we can see 19 out of 21 patients were quite satisfied with the cosmetic appearance of this procedure. Now let's look at the patients who were not happy. Let's look at what complications we had. So one patient out of 21 developed a delayed post-operative epithelial defect 1 month after the procedure. This was also my first case, so probably I kept the needle length a little bit more than was desirable. This finally healed within a week, but it left this central fading of the pigment, and the patient did not want a repeat procedure. This is the second case, the video of the girl that I showed you, and she had a little bit of this fading over a period of 1 year, and she underwent a repeat tattooing procedure. So that makes it very important that we counsel these patients that they might require a repeat procedure. And these are some of the cases, as we can see on slit lamp, the appearance, most of the cases do pretty well, and we get a nice smooth pigment. And the results are slightly better for patients who have normal intraocular pressure, who do not have a very irregular surface. So to conclude, corneal tattooing helps greatly in improving the cosmesis, in disfiguring corneal scars, even in patients who might have a total cataract and PL negative or pre-thicical, where we don't want to go ahead with the cataract surgery. It is a safe procedure with minimal complications, and it is important for us to inform these patients the pigment can fade over a period of time. Pre-operative counseling is important. Also, it is important for us to tell them to keep realistic expectations that this eye is not exactly going to look like their other eye. Thank you.
Thank you, Dr. Ikeda. That was a lovely presentation. Question to the panelists are, what do you think are the downside, and do you take different pigments for different colored iridis of the other eye? Dr. Rajesh Sinha sir, Dr. Bhupesh Singh, Dr. Tuhin.
Actually, that's not many times needed. Although you can take platinum chloride that can have a little brownish kind of appearance, but then it has a cost. But the simple India ink, which gives a black color, that works quite well. And basically, the person wants cosmesis, and when you see the person naked eye without seeing on slit lamp, then many times since the Indian eyes are quite they are darkly pigmented iris, so it works quite well. And I must say that Ikeda very nicely covered everything. And I was once, I don't have a tattoo gun, so I don't use it. I mostly do intrastromal. But as very rightly pointed out, that in some cases wherein the cornea is very thin, it is very difficult to do intrastromal. And that was very rightly pointed out. So in such cases, of course, once I was planning to borrow it from her, but it did not happen. My staff could not go. But it was very nicely done, well presented. Okay, then. But as you said, that different designs can be done with different shades of contact lenses. If the patient is willing to wear contact lens, a little bit, literate kind of, a little bit, person who is aware about, hygiene, etc. Then different shades of cosmetic contact lenses are available. So there one can maintain even better cosmesis.
Yeah. Okay. Thank you. Thank you so much. Anybody wants to add anything before we go on to the next?
Very nice outcomes, Akida. And I personally use contact lenses and prosthesis for all my patients. So I want to ask one thing. So last week I got one patient who came for the normal patient with the normal vision, basically. And he came for the tattooing of the sclera. He wants to get some mole on the sclera. So can we make it with this gun?
So I don't think doing that is a very good idea. I think we should avoid tattooing of sclera in a seeing eye, because these are healthy eyes. When we are tattooing on the sclera, we have the ciliary body, all the structures underneath, and we don't want to damage the sclera just for a cosmetic outcome. So I don't think we should encourage that, and I think we should tell the patient, be happy that you have a normal looking eye, and please don't go ahead with corneal tattooing on your sclera.
I think in such cases we can customize the contact lens.
Yeah.
Get a customized contact lens to improve cosmesis if the patient is so much keen for that.
Right. Yeah. Thank you so much, everyone. We'll move on to the next talk by Dr. Anubha Rathi. Welcome. She'll be speaking to us on managing acute hydrops in keratoconus. Over to you. Yeah, we can see your slide.
Yeah, hi. Good evening. Thank you, Dr. Annika, for the introduction. I would like to thank Professor Rajesh Sinha, sir, for remembering me and including me in this evening's webinar. This topic actually is about management of corneal hydrops in keratoconus. It is about keratoconus in particular, but corneal hydrops can be seen in several other conditions as well. So for general ophthalmologist, I would like to cover a little bit about the various other situations where one can encounter this particular condition. So this is exactly how the presentation will go. We'll be beginning with understanding what is corneal hydrops, why it occurs in few situations which we will cover, and in whom should you suspect it, and how to identify what are the history pointers or the signs and symptoms, and what we need to do once we encounter this condition. So let's begin with what is corneal hydrops. So hydrops basically means anything which is full of liquid or hydra. So if you can see over here, this is the corneal cut section where there is a decimate membrane. There is a tear in the decimate membrane, and through that tear, the aqueous humor has entered the stroma. This can be either a spontaneous break or it can be induced by various other factors, all of which can lead to corneal hydrops. So this is how it looks like clinically, and this is how it looks like on imaging. So let's see why it occurs. So, there has to be a baseline corneal pathology, which could be aggravated by something like, an aggressive eye rubbing. And there could be a microtrauma or a tear in decimate membrane, which could be caused because of that, because of which is the aqueous would seep into the cornea and lead to fluid accumulation and separation of collagen lamellae. So this is how basic it can get. So how to identify the clinical history? Obviously, the pointer would be the patient would come to you with sudden diminution of vision. It is an acute emergency, so patient usually complain of sudden diminution, and they also complain of photophobia along with or without pain. There could be watering of the eye, there could be redness, and most importantly, they complain of whitish discoloration of cornea. So when you see this patient on the slit lamp, though this is obviously a finding which is easily picked up even on torchlight, but on slit lamp examination, even apart from imaging, it remains the gold standard for diagnosis. There would be associated conjunctival hyperemia, and there would be a stromal as well as an epithelial edema. In the cornea, there are various gradings which have been defined based on the size of the edema that you are dealing with. So if it is up to 3 millimeters, it is called as a grade 1 corneal edema. Between 3 to 5 millimeters, it is grade 2, and anything more than that is grade 3. There would be presence of these pockets, which you can make out here. There are some intrastromal fluid pockets, and these are also called intrastromal clefts. And so this is an extensive edema you see here, so you cannot really see the decimate. But if you can focus within the cornea, you can see DM split as well. So How can you use imaging in management of corneal hydrops? So there are several techniques which have been defined. ASOCT, that is the anterior segment optical coherence tomography, is the most commonly used technique since it is non-contact, easily can be used in the OPD setting. Also, it helps in objectively studying the course of the disease, also in assessing the response to the various management options very objectively. UBM obviously is there, but I feel there is not much added benefit as compared to ASOCT, rather it's a contact procedure. Confocal microscopy has been used in literature for corneal hydrops, but what it shows additionally is the presence of inflammatory cells. So that is something which can help us in connecting the dots between hydrops and possibly vascularization that results in these cases of advanced keratoconus, which can make these corneas prone to rejection later once they need keratoplasty. So what are our options? Because the topic today is management of corneal hydrops. I think it is important to know, first of all, when to manage and in which way to manage. So there are two options, obviously, in every situation. One is to either wait for a spontaneous resolution, or second is to intervene. So what do you understand by spontaneous resolution? So there is a natural course to the resolution of an acute corneal hydrops. So I was told in my residency time that every hydrops will resolve or perforate unless you do something or you intervene. And that is actually true. So what happens is there is a detached decimate membrane. If you want a good resolution to hydrops, naturally this detached decimate membrane should reattach to the posterior stroma, and then with time the edema will reduce. And with time, the endothelium will also migrate from the reattached DM to cover the gaps between these broken ends. That is how it should naturally happen, and hydrops should resolve. But this does not happen in all cases. And there are times when there is a lot of thinning that is associated. There are times when people have come with perforation just because they were waiting for a natural resolution of acute hydrops. Having said that, most often it will resolve naturally with assisted medical therapy. So why do you need to intervene then? So basically the thing is that almost all of these, this aspect of natural resolution or medical resolution depends on the depth of detachment and the size of the break. So there is a decimate membrane which is detached. On ASOCT, you can easily determine the depth of detachment. And if you look, you can even see the size of the break. Most often, natural resolution takes about 2 to 4 months. So this is a long time. So you might induce a scarring which could be visually impairing later. And then it could necessitate a corneal transplantation. So even contact lens may not work in such cases then. The persistent edema or the persistent inflammation that is there for 2 to 4 months may attract vessels and may lead to vascularization that can predispose to future graft rejection. Also, as I said, very severe hydrops can even lead to perforation, which is obviously a sight-threatening complication. So having understood that, yeah, intervention also is an option in acute corneal hydrops, I would still like to, for the knowledge of all the general ophthalmologists who have joined us, that there are 4 important aspects when it comes to conservative options. Even if we are opting for surgical treatment, these 4 should be tried first. So topical hyperosmotic agents have to be used to induce corneal detergence. Topical corticosteroids to be used to reduce the inflammation and incidence of neovascularization later. Topical cycloplegics may or may not be used to relieve the ciliary spasm based on the presence or absence of, if you see any ciliary spasm which is present. Topical anti-glaucoma drugs can be used routinely, basically to reduce the fluid ingress into the corneal stroma by keeping the IOP on the lower side. These conservative options are most suitable for shallow detachment and smaller size of breaks. And usually, if you take all these conservative options, the natural course becomes faster by at least a month. And again, the incidence of vision impairing scarring and the persistent edema which can happen with these still holds true, just as the natural course, natural healing was showing us. So this brings us to possible surgical intervention of acute hydrops. So surgical intervention, is most suitable when this is something we practice. So we try medical treatment first, and if 1 to 2 weeks of treatment does not give us any significant response, then we opt for a surgical intervention. So surgical intervention, most often, what was known till at least 2-3 years back was that it has to be an intracameral air or a gas injection, which is referred to as, pneumatic decimetopexy. But now compression sutures have also come into play. The other options of replacing the affected DM, they are more for theoretical sake. I believe we do not use them very frequently. These are acute inflamed eyes. It is better to avoid keratoplasty as much as possible at that stage. And when it comes to pneumatic decimetopexy, it's a very simple, basic procedure. We need to first make sure that we first of all choose what is the agent of choice that we are using, whether we are using air or gas. Air is most preferred, easily available, and has least side effects. So you have to perform an AC paracentesis first and foremost, and then we just posterior lip of this paracentesis is depressed a little so that a small amount of fluid egresses out of the anterior chamber. Then intracameral pilocarpine is injected to constrict the pupil just in order to avoid any iatrogenic lens injury. In particular, if you are using gas, which could be either C3F8 or SF6, this is a very, very essential step. You need to also make a peripheral iridectomy if you are doing a gas injection or doing a gas decimetopexy. And once this is done, initially for 4 to 7 minutes, you can achieve a complete fill on table. And then on table itself, partly the air can be bubbed out. And following which supine positioning has to be maintained for 4 to 6 hours. So how it works is something very, very similar to how pneumatic retinopexy works in retina. So it is simply, there is a tear and you are using a tamponade, which is internal tamponade, to try to bring these two edges close so that the edges seal and there is no further egress of fluid beyond this tear edge. So after this, I think these are the 3 major studies which came up on different intracameral agents which were used for decimetopexy, air as well as SF6 as well as C3F8. So most of them, while they were increasing the speed of resolution, but the final best corrected visual acuity was not changing as compared to the control groups in all the 3 studies. There was some change in the study by Dr. Anita Panda in 2007 published in Cornea, but then it was measured at 12 weeks and not after resolution of edema. So moreover, in all these studies, the most common complications with these injections, in particular the gas injection, was the IOP rise, the pupillary block, and subsequent development of cataract or glaucoma. So air injection still remains the most preferred one. And if you're using the others, then the precautions which I stated before have to be applied. So this brings us to something little relatively new, and a lot of us may be already practicing it as well. So this is something I like to teach my students now, because I feel we all have learned from the buckle when it comes to compression sutures. The concept sounded familiar the first time it was introduced to me. The thing is that, see, there are 2 edges of decimate membrane which are lying apart, and just like in buckle, all we do is we bring those 2 edges together. We are not directly suturing the 2 edges when it comes to compression sutures. So that is the reason why different people have different techniques of doing compression suturing. Some have done radial sutures, some have done, like in a case of PMCD, just peripheral radial sutures, interrupted ones. Some of them have done perpendicular to the decimate tear, wherein they have not even gone till 90%. All they did was they went till 60% depth of the cornea and detach the cornea mechanically, because you've put tight sutures. And because you have brought 2 edges of the decimate tear close to each other, natural healing takes over and the 2 edges oppose, just like they do in a retinal tear in post-buckle. So this brings me to one case. This is, a 13-year-old child who had a history of rubbing the eyes, had a history of VKC as well. and who presented to us with blurry vision for 2 weeks with whitish discoloration. So a local consult was done where Hydrops was duly diagnosed and hypertonic saline drops and ointment was started. So when he came to us, this is how the cornea looked like. This is the picture I showed in the beginning itself. And the patient's vision was counting finger close to face. This is one of the first cases where my colleague Dr. Sunita did this particular technique of compression sutures. This particular slide is basically to highlight that when you look at Hydrops, never forget the other eye. So if there is a acute corneal hydrops in one eye, the other eye or the fellow eye needs to be seen, and if required in future, as early as possible, you should do a collagen cross-linking of that eye to prevent something similar happening in the fellow eye. This particular patient unfortunately had an advanced keratoconus in the other eye as well, which was not amenable to CXL because the thinnest pachymetry was noted to be quite thin. And this patient hence was initiated on medical management first, and we started with topical low potency steroids and topical anti-glaucoma medication along with hypertonic saline. We decided to review after 1 week when slightly the edema reduced, but it was more or less status quo when we saw on slit examination. This is when we decided to go ahead with compression sutures. This will be a slightly different technique. So this is an air injection which is placed first after making a paracentesis. Multiple interrupted sutures starting from the periphery moving towards the center of cornea are placed. In the centralmost area, a box suture is placed to tightly close the apex of the cone. And once this is multiple interrupted sutures, once all of them are placed and the air bubble is slightly reduced, and after that the bandage contact lens is placed after burying all the sutures. So this patient on day 1 itself was seen to have quite a reduction in the in the corneal edema. A very small air bubble which can be seen just under the lid was remaining because we had reduced the bubble size on the table itself. And on anterior segmentosity, you can see that the edema has significantly reduced. Obviously, you can see the tight sutures and the change in contour of the cornea. In follow-up on day 7, the contour improved slightly, the corneal contour, and the edema further reduced, and the best corrected vision had improved, while unaided vision was 2400. This patient at 1 month itself, we removed all the sutures under general anesthesia. It was a child, so we took up for suture removal at 1 month under GA. And at 2 months follow-up, it was noted that the best corrected vision with contact lenses was 20/80, while the cornea can be seen to have quite a good contour rather than what we saw on the first day. So this is one patient where we had an excellent outcome after compression sutures. So these are basically various techniques which you can do, but you should always begin with medical management and always make sure that we have seen what is the cause of Hydrops in the patient, whether it is actually keratoconus you're dealing with, or is it a PMCD or a Terrien's marginal degeneration or any other cause of corneal hydrops, such as post-refractive surgery. Even post-traumatic corneal hydrops has been seen. In children, in very young children, it could be because of infantile glaucoma or it could be because of a forceps delivery. So basically the first thing is to determine the cause. And in this particular first point, like the fellow eye examination can actually help you tremendously. So if the fellow eye has keratoconus, obviously you're dealing with a keratoconus leading to a hydrops. And seeing the other eye, doing the topography, making sure you do a cross-linking if the other eye cross-linking is possible, and initiating medical therapy with anti-inflammatories, with cycloplegia, topical hypotensive and hypertonic saline treatment is mandatory. Once that is done, and for 1 to 2 weeks, in case medical response is not good, or the hydrops is involving central cornea, and you worry that the scar, if it is too big, is going to need a transplant in future, then going for an adjunctive surgical intervention is a good idea. And going for air decimetopexy or compressive sutures could be a personal choice, but compressive sutures have been shown to be safe, effective options for faster resolution. Thank you.
Thank you so much, Excellent presentation. I think you have covered it so beautifully and showed us all the videos also. One question I would like to ask you is, can this recur again? And if you have put compression sutures already and the patient gets this problem again, would you use the same procedure or would you try and change the procedure in the second time?
Yes, Dr. Hanika, actually, most often once the hydrops has occurred, hydrops has scarred, then it is unlikely that in the same pockets again the fluid will get filled because you will have scarring. But maybe doing a compression suture again is not usually needed, whereas decimatopexies, the pneumatic decimatopexies were known to be required multiple sittings as well, like maybe once or twice. But compression sutures, you have to be as aggressive as possible in the first sitting itself and try to close the DM tear, at least bring it closer as much as possible. But if you, another thing is, so I have seen this because, fellows, when they are here, like we are at LVP, so sometimes once you learn a new technique, everybody gets very interested in practicing it in almost everything. You have to choose the right patient, because if you are doing it, suppose let's say in a corneal hydrops where already for 2 months the patient has had edema and the DM margins are all thickened and fibrosed, it is unlikely to respond to your compression sutures. So you have to do a thorough examination and ASOCT before choosing the technique of choice.
Thank you. Thank you so much, ma'am. Would anybody of the panelists like to say something or add anything?
Yes, so definitely, Dr. Anubha, compression suture is a newer treatment modality, and I think we are shifting from air tamponade to compression sutures in most of our cases. So I had one case in which I did a compression sutures around 10 years before. So when I removed the sutures after 2 months in that patient again landed up in the hydrops. So that was surprising for me, and ultimately I have to do the keratoplasty for that patient. So it is possible that you can again have the hydrops, maybe in some other quadrant, maybe in the same quadrant, but it is possible. And other thing is we have to delay the suture removal as much as possible. 1 month suture removal is not advisable in hydrop cases.
Yeah.
Although you can do that in normal cases, but extreme hydrop, bigger cleft, always wait for 2-3 months until it starts scarring. It shows the scars. Then you remove the sutures. So that is I think.
I
Is there
agree,
any
Dr. Bhupesh.
criteria on ASOCT that when you then you decide to remove the sutures once all the clefts are cleared or something?
So definitely cleft, so usually clears in 2 weeks time. Cornea flattens in 2 weeks time. Patient regain good vision, but still you have to wait for 2-3 months because these corneas are very weak. You remove the suture immediately. Next day patient comes with the hydrops. I've seen those cases. So better to wait for 2-3 months then remove. There is no hurry. So that's the thing.
Dr. Rajesh Sinha, have you ever seen acute hydrops in a post C3R patient?
Yes. In post C3R patients also, we have seen acute hydrops. And just
would
to
the management change in these patients?
Sorry?
Would the management change?
No, the
compared
management
to
will not change. It will remain the same. But one thing what I wanted to add in this, that what Dr. Anubha very nicely presented everything. If we have microscope integrated OCT, then with the help of that, you can actually, instead of putting the sutures intrastomally, we can rupture it with a MVR blade. We can rupture those clefts with MVR blade, and that releases fluid. I have some videos also wherein I've done some cases, and it works well. I mean, clefts, they become flat immediately. As far as compression suture is concerned, I'll be presenting one very interesting article during that Sarange regarding the causation of acute hydrops and the different concept that has been brought about as far as causation of acute hydrops is concerned, and why compression suture can be helpful, and why a combination of compression suture and gas accelerates the resolution of hydrop. So when I'll be discussing about that, we can do that, because
Thank you.
no point
Thank you so
repeating
much.
it.
Yeah, so we move on to the next talk. Thank you so much, Dr. Anubha. We move on to the next talk by Dr. Sridevi Nair. She will be speaking to us on supratarsal injection of steroids in VKC. Over to you.
Hi, good evening, everyone. I hope my slide is visible.
Yes.
Yeah, I'd like to thank Rajesh sir and AIOS-ARC for this opportunity. So I'll be speaking on the steroid injection, supratarsal steroid injection in cases of VKC. VKC, as we all know, it's a chronic bilateral seasonal allergic inflammatory disease, and it primarily involves the bulbar and tarsal conjunctiva. So it is a chronic condition, but it is characterized by acute exacerbations, and usually it affects like school-going kids. Males are more commonly affected. The disease, though self-limited, can cause several complications in lieu of the chronic inflammation, eye rubbing, and the chronic steroid use in these cases. So the clinical presentations for this condition can be either the palpable form, which is more common in our setup, wherein the patients present with tarsal papillae, sometimes in a cobblestone pattern, and the bulbar or limbal presentation, wherein we have the Horner-Trantra spots as well as the bulbar conjunctival papillae, and the mixed form where we have both. So the mixed form is also quite common. And the treatment approach for this condition, it follows a step ladder approach, wherein we start with the basic things such as cool compresses, avoiding the allergens, maintaining the being in a cooler ambient temperature. Then we move on to lubricants and antihistaminics. Then we move on to topical steroids, which might be given as as rescue therapy, as on and off courses, or whenever they have an acute episode, and immunomodulators, which can help as a long-term therapy to prevent the acute exacerbations. And basically, the role of supratarsal injection comes in recalcitrant cases which are not responding to all of these measures. And that is where we should consider giving this form of therapy. So the indications for supratarsal steroid injection in VKC is basically advanced cases that are refractory to maximum medical therapy, and cases which are not responding to your routine, like maybe the chronic immunomodulator therapy that you're giving these patients, in addition to the steroid pulses that are being given, topical steroid pulses. And the patients usually have large cobblestone papillae with severe limbal involvement. Even shield ulcers respond well to supratarsal steroid injections, which usually people think that it may not help, but it does help. And there is caution to be exercised, especially in case of steroid responders, which we'll be discussing in the further slides. So the technique is not very complex. Basically, first you put some proparacaine drops in the patient's eye so that the anesthesia, and then you use a 26 gauge needle, which is placed subconjunctivally about 0.5 to 1 mm above the superior tarsal border of your upper lid. And first you inject some anesthetic, local anesthetic 2% lidocaine, about 0.25 ml is good enough. You should take care to avoid the marginal arcade vessel, which is usually lower down. It's around 3 mm above your lid margin, whereas your the injection is above the tarsal border. So just make sure that you don't inject at the marginal arcade vessel site. And the important sign to look for is that there should be a ballooning of the conjunctiva, as you'll be injecting between the conjunctiva and the Mueller's muscle. So this is where you will be injecting the supratarsal steroid. It is just below the conjunctiva and above the Mueller's muscle, and there should be a ballooning of the conjunctiva right above the upper border of the tarsus. So you can either use triamcinolone or dexamethasone. I commonly use triamcinolone, which is 20 mg in 0.5 ml. And this first, you have to just disinfect your area locally with 5% betadine solution, following which you inject the lidocaine, again in the same site at the upper border of the tarsus, below the between the conjunctiva and the Mueller's muscle, and you look for some ballooning. Then the needle is injected parallel to the tarsus. So this ballooning is very important. And you can inject it in multiple jets. And that's it. And then you just apply some cotton swab on your sites of injection. Because it's often not possible to inject the entire amount in a single area because of the limited space in that region. So you might need to give it in multiple shots. The post-operative management, so I usually do not give the topical steroids because we've already given a steroid depot in these patients, but make sure that you continue all the other maintenance therapy, which includes topical histaminics, any cyclosporins or calcineurin inhibitors that the patient is taking, frequent lubricants, and topical antibiotics prophylactically if a shield ulcer is present. So this is a case wherein we had bilateral severe VKC with a shield ulcer in the right eye, as we can see, and the patient was refractory to topical steroid therapy. So the patient was planned for triamcinolone injection in the right eye. As you can see on day 7 post-op, there is some improvement, and by 14 day, the inflammation has more or less subsided and reduced significantly. Now, the shield ulcer in the right eye, as you can see, has also improved significantly by day 14, and it's nearly healed. In the left eye, again, the same treatment was given, and we observed that there was some partial flattening of the papillae by day 14, but by 6 weeks, we saw there was a recurrence of papillae. So this made us repeat the injection at 6 weeks, and by 8 weeks, we realized, we saw that the patient had resolved, the papillae had resolved. So outcomes, basically, this is a temporary measure for the suppression of inflammation in VKC cases, and the improvement is observed usually within 1 to 5 days. The improvement in clinical symptoms can be visualized as a decrease in the cobblestone papillae, or limbal thickening and edema will also reduce, and the shield ulcer, which usually takes about 2 weeks to resolve. Repeat injections may be needed. Usually it's after 8 to 12 weeks, and may be needed in 10 to 35 cases, because these are anyway severe cases. So recurrence is common, and they might be not amenable to just one injection. Complications. So this is probably the most important slide here, because the most common complication with this, that so subconjunctival hemorrhage is not a worrisome complication, but ocular hypertension, which is seen in 3 to 6%, is something that you need to look out for. And it should never be given in steroid responders, because I have had an experience wherein a patient of severe VKC refractory to conventional treatment was not a known steroid responder. We gave him supratarsal steroid, and post-operatively his IOP shot up to 40-50 mmHg. It was not responding to anti-glaucoma medications. He was, I think, a 14-year-old young male patient. And sadly, since this is a steroid depot, we cannot just stop the treatment. Unlike topical steroids drops, where you can stop the treatment once you notice IOP response, in this case you can't do anything about it once you've injected it, other than just give the anti-glaucoma medications. That patient, eventually he required a bilateral trabeculectomy for this, and also developed some significant amount of optic nerve head cupping. So ocular hypertension is something that you need to look out for in these cases. The other complications are rarer. Conjunctival scarring is not that significant. Fat atrophy also not very worrisome. And any secondary infection or motility disturbances can be avoided if you just follow the proper technique of injection. So to summarize, supratarsal injection, it's a very useful treatment modality in recalcitrant cases of VKC, and a dramatic and prompt improvement in symptoms can be observed, which actually improves the compliance of the patient for further therapy, especially in recalcitrant cases. And it's just a temporary measure to suppress the inflammation, and it does not induce any remission, like a complete remission, which should be kept in mind. And it is important to therefore it's important to continue any topical maintenance therapy even after the injection. And a lot of caution should be exercised, especially if any steroid responder, it's a big no, you should never give it in such patients. And repeat injections may be needed in up to 1/3 of the patients. Thank you.
Thank you so much, ma'am, for that
Thank
excellent presentation.
Yeah.
To all the panelists, would you like to add something or ask any question?
I would just say that in my experience, obviously, I've been injecting these in severe cases. So repeat injections are invariably required in most of the cases, because all these have very bad cobblestoning, and in one injection, those don't get flattened. So that is something that we have to be mentally prepared. And what she pointed out, very rightly pointed out, that we have to be really careful in watching for the rise in IOP. That's very important.
Thank you so much, ma'am. So we'll move on to the last talk by Dr. Anil Radhakrishnan. He would be speaking to us on post-cataract surgery DMD. Over to you, sir.
Yeah, thank you. I'll just take my presentation.
We are not able to see,
Sorry,
sir.
I'm not able to.
Yeah.
Yeah, just
You have to
a
first
minute.
open it, minimize it, and then
Yeah,
you
that's
can
what I did, but yeah.
close it and then again start. Sir.
Yeah, okay, I'll do that.
Yeah. Can somebody from the AV team guide him? So you need to open it, minimize it, and then share.
Yeah, that's what I'm trying to do, but it's.
Okay.
Can I help, Dr. Anil, anyway?
Yeah.
I'll just try once more.
Yeah.
Yeah, I need help.
Are you on a Windows or a Mac, doctor?
Let me move
I'm
on
on
to
Mac.
the Sarange this thing and then come back. Or
Dr. Mac, Dr. Anil, you will have to give permission in your Mac, and I believe it must be blocking. If you can go to your security and privacy, there you can find Zoom, and you can just check the.
Can we go on with the Sarange then now?
I think that would be better.
Yeah, yeah. In the meantime, you can please guide him. Yeah, we'd like to now invite Professor Dr. Rajesh Sinha sir for his talk on the Sarange, and this is the hot and sizzling gist of journal articles from Cornea.
Thank you, Dr. Naga. And it's a wonderful idea and a wonderful concept of giving Sarange. And this is basically related to some topics. And based on those topics, some interesting articles that have come up. So I'll be basically covering up 4 things, 4 articles related to 4 pertinent topics, which give some message and which have, which are trying to or have caused change in terms of management protocol. So the first thing that I'll be discussing is the efficacy of CXL in sitting position. It's a new kid on the block, and the efficacy will be seen by demarcation line depth. As we know that demarcation line is something which is seen at the junction of the cross-linked and non-cross-linked cornea, and that is what we normally get, a demarcation line at about 250, close to 250 microns, because the UV rays gets absorbed up to 200 microns, and the riboflavin also gets absorbed in that area, and both these cause formation of free oxygen radicals, and they cause covalent bond, and that's how the demarcation line is seen, and that is seen on OCT. Now, CXL is an established modality, we all know, and newer modifications are being tried to make it more doable and more patient-friendly. And this is one interesting article published by Farhad Hafezi Group, who is known for his work in cross-linking. And he mentions with his CXL device, excuse me, which is CI device, which can be fitted on slit lamp. And he does cross-linking by asking the patient to sit on slit lamp and in sitting posture. And he found out that the demarcation line depth was comparable to that of the cases wherein it was done in supine position. The average post-operative demarcation line, what he told, was 189.4 microns with a standard deviation, so close to 200 microns. Now, the factors that are affecting efficacy of CXL are the presence of oxygen in the corneal stroma, irradiation with UV light, and presence of riboflavin. And these, as I said earlier, that riboflavin is a photosensitizer. So it results in formation of free oxygen radicals, and that results in collagen bonding between the collagen fibrils. And that is how it works. So the diffusion of oxygen molecules into the cornea should not be affected by position of the patient, or the diffusion of riboflavin should also be not affected by the position of the patient. This is what was felt by this group, and that is why they did the study. And they told that there are significant advantages, that CXL need not be performed in an operating room, can be performed instead in a minor procedure room, and or even in a doctor's office, like an OPD procedure. And eye hospitals which are not equipped with good operating theater can also do it, even in rural settings, and it reduces cost and democratizes the procedure to a far wider population. This is another study which states that according to Lambert-Weir law, 65% of UV radiation is absorbed in the first 200 microns, and that's why the demarcation line is seen at around 250 microns, because that is the level up to which cross-linking works. And that's why the demarcation line is seen at a depth of 250 to 300 microns. Now, the take-home message from this article is that cross-linking can be done on slit lamp, and posture of patient does not affect the efficacy of CXL. And performing CXL in sitting position on slit lamp is easier. But there are a few points which raise a little bit of question mark, that the demarcation line depth that was shown was average was 189 microns. Maybe you can keep 200 microns, which perhaps is slightly lesser than the average of most of the articles, and in our experience as well, wherein we have seen demarcation line between 250 to 300 microns. So that is also an important issue. So maybe the case selection was different, the thickness of the cornea was different. All these factors need to be studied, and maybe more study needs to be done in order to really understand that cross-linking is as effective in sitting position, which it should be, because there is no other reason, there's no logic that makes it more effective in lying position. However, whether it is comfortable for the patient putting his chin on the slit lamp continuously for, even if you're doing accelerated cross-linking, then it takes some time. So whether it is comfortable for the patient or not, it may be. So that needs to be known from the patient by doing sort of a survey kind of a thing. So this is something, this article I felt was quite interesting. So I thought I should bring it to the notice of all. And a lot of people now, even in India, people have started doing cross-linking on slit lamp. So let's see with time we'll get to know more about it. Another thing that I'm going to discuss today is post-LASIK or post-PRK keratitis. This was a very interesting article. It was a review article on infectious keratitis after keratorefractive surgery. And the idea was to summarize the clinical manifestation, microbiological profile, and prognosis of corneal infections after different keratorefractive surgeries. It included 128 full-text articles, and data of 84 articles were included in the review. And they found out that PRK carries a higher risk of developing post-operative microbial keratitis than LASIK, and that is understandable because you debride the epithelium and you put a bandage contact lens, so the risk of infection because of that increases. This is how it looks like a post-LASIK infection case. And most common organism in this review article, and most of us, we have felt that the most common organism isolated have been Staph aureus, followed by Mycobacterium, coagulase negative Staphylococcus, etc. And most infections occur within first week of surgery, but there are a group of patients who have late infection as well. So the early onset group has Staph aureus as the commonest isolate, and in the late onset group, it's the Mycobacterium, which is the commonest isolate. The idea of knowing all these and doing the literature review is not just academic, but it is also clinical, because we have to start the empirical treatment immediately, even before we get the results of investigation. So if we have an early onset infection, we can think in the lines of Staph aureus or there can be other infections as well. Just like recently, we have admitted a case of post PRK keratitis, which showed to the treating doctor in 2 days' time with ring infiltrate and severe infection. So that was that, and that was clinically Pseudomonas, and that he was sent to us and we admitted, and that was proven to be a Pseudomonas as well. However, overall, early onset infections, Staph aureus has been commonest, and late onset mycobacterium. As far as surgical intervention is concerned, flap lift is something which needs to be done in a large number of cases. As you can see here, close to 50% of cases you do require flap lifting, and flap amputation is required in, again, a significant number of cases in order to get a good response. And in smile infection, interface wash is needed. So the idea is that your antibiotic should reach the interface, or the antibiotic should have a good penetration. And the reason for flap amputation or the flap lift is that, or the reason for interface wash and smile is that only. And the factors responsible are like intraoperative contaminants were found to be the most frequent cause of post-classic infection, and the possible source of contamination include so these are something which is understandable, which we all understand. So cleaning the eyelids within 3 days preoperatively was suggested to reduce the bacterial load. And there was no correlation found between the flap type, like microkeratome or femtosecond laser. There was no difference as far as the risk of microbial keratitis is concerned. Now, the third thing that I'll be talking about is role of topical insulin for refractory persistent corneal epithelial defects. And persistent epithelial defect is defined as a corneal defect, epithelial defect, with a minimum area of 2 square millimeter that continues without improvement for more than 2 weeks despite conventional treatment. The reason is this, why we call it PED, because the normal cornea has a epithelial regeneration time of 7 to 10 days. So any epithelial defect will heal during that period. But if it doesn't heal beyond 14 days, then it is called persistent. And whereas there are treatment options like non-preserved lubricants, withdrawal of epithelial toxic drugs, application of bandage contact lens, plugs, autologous serum, PRP, amniotic membrane, neurotization, etc. This is a very interesting article that has come up, the role of topical insulin for refractory PED. The objective was to evaluate its role in these cases, and the rationale was that neurotrophic factors like insulin-like growth factor 1 is present in the corneal epithelium, and that can promote wound healing. And studies have also, this interesting study has also shown, given the reference of one study, which has shown that there was presence of insulin also in TFL that has been detected, and insulin-like growth factor is also present in corneal epithelium, and that is something that was the reason why they did this study, and they found out that the PED improved, it healed in a reasonably good time. The patients were analyzed on by taking slit lamp photograph and analyzed on ImageJ software. And the insulin eye drops concentration was 1 international unit per ml. And it was diluted in polyethylene glycol, that is the lubricant drop that we use normally. And then it was refrigerated and used for 1 month once prepared. And 21 patients with PED were treated, out of which in 17 patients, it improved. These are the cases that were taken, like infective keratitis, followed by PED followed by calcium keratopathy, PED due to leg ophthalmos, ocular surgery, bullous keratopathy, hepatic eye disease, etc. And 62% patients used bandage contact lens along with insulin therapy. And mean epithelial defect was 17.6 millimeters square. And the mean time until reepithelialization in complete closure of PED in 17 patients was 34 days or 35 days, you can say. And in remaining 4 patients during that period, the PED reduction was 91.5%. And there was no adverse effect. This is how it looked like. So they concluded that topical insulin therapy does promote epithelial healing in cases of PED. And the advantage is this, that it is easily available, cost effective, and ease of delivery with no side effects. So, but there are certain limitations as well, but like, the patient profile was heterogeneous, there was lack of control group. Then in 61% patients, bandage contact lens was also used. And the mechanism by which insulin restores epithelialization is still not fully known, although they have shown the presence of insulin growth factor, but still it is not very clear that whether that is directly responsible for epithelial healing. So the take-home message is that insulin can be tried in terms of its epithelial healing effect. So it can be tried in cases and seen. It appears to be a promising thing, but only time will tell. And this is the last thing that I'm going to tell, which I was talking about earlier. A very interesting article published by Jack Parker in 2019, that whether Descemet's membrane rupture is the root cause of corneal hydrops in keratoconic eyes. Acute hydrops, very nicely presented by Dr. Anuba, and it is characterized by the accumulation of fluid into the cornea, and it is believed to happen due to rupture of Descemet's membrane. And this is how it looks like. Now, this was the question in this article, that whether DM rupture is the root cause. And why they felt and why they put this question was based on certain facts. One was this, that of course the tear and Descemet membrane allows the aqueous to enter into a corneal stroma. This is what we all believe. The second thing is that the patient of keratoconus with FECD, you know that the two dystrophies which are coexistent, the common ones, the commonest one is keratoconus with FECD. Now, keratoconus with FECD wherein DMEC has been done. So if you do, remove the Descemet, it does not increase, percolation of fluid. This was the logic that was given, rationale given. But I would rather add to that rationale that we have been doing DVEC also in some of the cases wherein we remove Descemet's membrane and in the area where there are guttae, and that area is bare and then Descemet comes up. So that is a sort of a form of a tear only, but it does not cause hydrops. So why in keratoconus, if there is a tear in Descemet, it causes hydrops? And that is what they did the study. It was a retrospective study wherein one group, they included 16 eyes of 10 patients with keratoconus with Fuchs endothelial dystrophy who underwent DMEC. And in the other group, 5 eyes of 5 patients who developed inadvertent perforation during donor bed preparation for Bowman membrane transplantation. So what they found out was no eye under DMEC group demonstrated acute hydrops, either by direct inspection or by evaluation with ASOCT. And all the eyes under BMT, that is Bowman membrane transplantation group, who had perforation, they developed acute hydrops. So this was how it looked like. So the study results challenged the consensus that corneal hydrops primarily develops to a Descemet membrane tear. And the reason, I'll just come to that, this was a comment by Dr. Harminder Dua also, that it is not just the Descemet membrane, but what they believe is that it is the tear in the pre-Descemet layer that results in the fluid getting into the stroma, because pre-Descemet layer is a tough layer, and people who do DALC, they know that if it's a type 1 bubble, they're not scared of its perforation and very Easily they dissect, do everything. But if it's a type 2 bubble, there is some risk of perforation. Now, so that is a tough layer. So it will not allow the fluid to enter into the stroma. And that is what, if we do DVEC, then the fluid does not enter into the stroma. But if there's a rupture in the Duas layer, then that barrier goes away. The other thing that they said, that there can be other cases also. You do get a case of a trauma wherein there can be a trauma to the Duas layer as well. But it seals, it closes, it doesn't cause acute hydrops. So why it happens in keratoconus? It's basically because of the rupture of the Duas layer and the stroma in the keratoconus, which is in tension. It is causing a stretching, and that results in stretching of that area and percolation of fluid, imbibition of fluid from the aqueous into the stroma, resulting in acute hydrops. So that was really very interesting. And that's what they concluded, that rupture of both Duas layer and Descemet's layer is required for development of acute corneal hydrops in patients with keratoconus. So this article I felt was very interesting, and that's why I thought that it's worth presenting this thing. So any comment from any of you?
Yeah. Very interesting presentation,
Yeah,
sir, and
excellent, excellent, sir.
lot of
Yeah.
insight. Really wonderful summarize. Very nice, sir.
So I also felt that I have done DVEC.
Great.
About the last article. Other articles we all know. I have done DVEC in a few cases, and they have responded well. In a couple of cases, they have not responded well. It depends on the endothelial function that is there. But in a few, they have responded well. But even if they have not responded well, hydrops has not formed. So this means that the rupture of this Duas layer is also essential, and rupture with stretch that is there in the stroma, that perhaps is the factor. We have to...
Very nice insights, sir. Very interesting. Thank you so much, sir, for the excellent presentation. Really nice.
Thank you.
Excellent. Great, great. Dr. Radhakrishnan, are you ready with your presentation?
Yeah, I have.
Yeah. Yes, sir. Please share it. Yes. Thank you.
Yeah, please forgive me. I think there is some issue with this, Can the AV team please help me? I made those recommendation what you suggested.
Which one is your presentation?
No, that is on this one, pneumodesmetopexy, DM detachment.
Yeah.
AV team, please help him. Yeah. AV team.
I think no one is there.
Hello.
So we were able to see. You can share please again.
Yeah, we could see that. Just share it again.
No, I think it was not that one, Yeah, okay, fine.
So the blue green, yeah.
Yeah.
Yes.
Perfect. You can
Yes.
play. You can click the play on the top, sir.
Yeah, okay, fine. Yeah, thank you so much, especially Professor Rajesh Sinha, for this great opportunity. I think AIOS ARC is taking a lot of effort. I really appreciate. Especially, I like this concept of Sarange. And I think the gist of information that you give is really great. Unfortunately, there is an inverse relationship between the interest of ARC and the interest of postgraduates. That's what I've seen. Because there is a lot of material available online, I believe. So my short talk would be on management of Descemet's membrane detachment, which was covered partially, also known as pneumodesmetopexy. So Descemet's membrane is a thick extracellular matrix. It has two layers, the anterior banded zone, which is the right from birth, and the posterior layer, which keeps on increasing in thickness over a period of time. So as was shown multiple times in young people, it tends to curl up. I think it is OCT image in which you can see a curl of the Descemet's membrane. If it's a partial DM detachment near side port, it's very common after cataract surgery. And there need not be much worry regarding that. But if you insert an anterior chamber maintainer, quite often the DM gets detached. And if it comes to the visual axis, obviously you have to intervene. Quite often it's limited only to the peripheral 1 millimeter of the cornea, which is pretty inconsequential. So what are the causes? It is generally speaking, it's slightly more common in older people. If you use blunt instruments, especially blunt keratome, and when you extend the wound, that is especially seen when you do SACS in a large black cataract. If you extend the wound at the periphery, definitely you can see a bit of DM getting folded and all that. The other thing, what happens quite commonly with the phacoprobe is while going in with irrigation on, that usually happens with novice surgeons. And at the rough edges of the holes in the sleeve is the culprit usually. It also can happen during irrigation aspiration or during IOL insertion as well. But phacoprobe and keratome, these are the two common areas where it can happen. So this is a video of a patient in whom it was seen to, the patient suddenly had a DM detachment. I think nobody saw anything in real speed. But if you see it in very slow speed, you can see that here. I'll pause it here once more. You can see that DM detachment has come. This happened when the irrigation port came into the wound. And from here it started. So this was the genesis of the DM detachment. So this, in the slow speed, I made this video, I edited this. And in that you can see the DM detachment happening. So when you have a DM detachment, you, if it is, unless it is really inconsequential, you can stop proceeding. You can put an intracameral air injection, fill the air with anterior chamber with air. And the entry site must always be away from the site of DM detachment. So if you have a DM detachment, this is what we do. You go away from the area of DM detachment, use a sharp needle and inject air so that this membrane is displaced to other side. Is an example of a patient who came in the first post-op day with DM detachment, had diffuse corneal edema, some of it encroaching the visual axis. And in the slit image, you can see that there is a membranous structure behind your cornea. And there is microcystic as well as stromal edema, which is evident in OCT as well. You put intracameral C3F8 and it gets resolved within a day. I didn't get the proper video, but this is a video which I somehow found out. And this is, you put the air from the opposite side, away from the area of detachment, and just wait for some time. And I generally tend to do interface venting, especially if it is more than a day. So if you go across, you see the wrinkles on the Descemet's membrane. If there is any fluid, that also you can drain, just like what you do in DSEK. Day 1 picture of the patient in which C3F8 bubble is there, and day 7 in which most of it has got absorbed. This is another patient who had a DM detachment, which was actually referred. And in this patient, you can see that there is a small bit of epinuclear particle between the Descemet's membrane and the stroma. So this is seen in the slit photograph. So it's important that you remove that so that the DM can sit flat on the stroma. So go at the area of epinuclear piece. And I removed it piecemeal. And then air injection was done. And waited till the DM attaches. I think what studies have shown is that it is better to wait for 15 to 20 minutes. I know that there is a constraint of time. I usually post it as the last case and I do it. So if you keep 15 minutes, 15 to 20 minutes, usually it gets attached. Then I reduce the size of the air bubble or the C3F8 or SF6, whichever gas I'm using. Same patient, there are two switches there, one at the side port and one at the area where I made the incision. Rarely we come across situations where you have a taut DM. Like this is not exactly in a patient who's undergone cataract surgery. This is after a DALC. So you see that there's a space between the Descemet's membrane and the stroma, in which case you can make this incisions, just like relaxing retinotomy is what the retina surgeons do. You can make a cut in the peripheral part of the Descemet's membrane and then put gas, and over a period of time it heals. This is a patient who had undergone a DALC and had this and got settled after this particular procedure. So I don't have a great experience, but I've been, I think, close to 47 eyes I've done. And in most of the cases, DM could be attached. And corneal clarity was achieved in, again, most of the cases. And whenever the cornea becomes clear, there will be improvement in the visual acuity also. There were quite a few complications. IOP rise was seen in about, I think, about 20% of people, even after removing the SF6 after about 20 minutes. Pupillary block was seen in 3, which could be easily be controlled by doing the AC burping on the next day morning itself. One patient had a decompression retinopathy. Like we had the high sudden increase in the IOP, we did burping under the slit lamp, and the patient was not improving to 6/6. The vision was hovering around 6/18. We saw the retina, he had decompression retinopathy. I think 2 patients had opacification of the intraocular lens. This typically, as you know, happens in hydrophilic intraocular lenses, and it exactly corresponds to the area, pupillary area. So this is after dilatation. So in the pupillary area, you can see the opacification. So I don't think I'll go to much details, but I would say that some eyes are really predisposed for dim detachment. What is postulated is the abnormal adhesion between the stroma and the Descemet's membrane, probably a functional deficiency of the TGF-beta 1. I'd like to conclude saying that pneumodescemetopexy is a very good procedure and it works very well in most of the cases. The corneal clarity will depend on the endothelium. If the endothelium is damaged, and even if you attach the endothelium, it will not serve its function. So the cornea will not gain its clarity. If it's important to pay attention to the details, I think a lot of cataract surgeons, they put air and they put maybe half chamber or 70%, and they'll make the patient sit up like in any other cataract surgery. I think it's important that we have to wait for some time for the Descemet's membrane, which is detached, to attach back to the stroma so that it can function properly. If you pay attention to the details, a lot of the complications can be taken care of. Thank you.
Thank you so much, sir, for a lovely presentation. Thank you, everyone. And we now come to the end of our ARS ARC webinar along with ISCARIS. So I'd like to profusely thank Dr. Samar Basat, sir, who is President ARS, Dr. Prashant Bavankule, Chairman ARC, and Team ISCARIS, Dr. Titial, sir, Dr. Namrata Sharma, ma'am, Dr. Rajesh Sinha, sir, for collaborating with ARS ARC for such a wonderful webinar. Would also like to thank the expert panel and all the speakers for a wonderful presentation as well as very good interactive discussions, I think, and I'm definitely sure all our delegates, audience, the general ophthalmologists are going to really benefit from today's webinar. So thank you all once again. Thank you and AV team for guiding us. Thank you so
Big
much.
thanks to Dr. Naga Arur for moderating it very well.
Thank you so much, sir. My pleasure and honor, as always.
Thank you. Okay, bye. Good night.
Thank you, everyone. Thank you, sir. Thank you.